Amy Freeman-Sanderson presented her research at the 2017 SPA National Conference. Her presentation was entitled Speech Pathology in ICU, Early Targeted Intervention for Return of Voice in Tracheostomy Patients Improves Quality of Life. She's going to tell us about her study now.
Thanks for that. My study was a first study in Australia looking at the intervention we provide to tracheostomy patients in intensive care. Across Australia and New Zealand, about 160,000 people would be admitted to units this year, and a quarter of those patients will require a tracheostomy. When a tracheostomy is put in, patients can temporarily lose their voice because air is rediverted away from the larynx back to the ventilator. And during this time, patients have lost their primary mode of communication, their voice. So it's very distressing for them. They can't communicate their comfort needs or their care needs. And sadly, 20 to 30% of patients will pass away with the trachea and never be able to speak again. There's a real opportunity for speech pathologists to work within this area, looking at provision of communication and re-establishing primary means of communication. Standard practice is looking at when patients come off the ventilator, but we wanted to see if we could intervene early while they were still on the ventilator to see if it improved time to speaking, but also to see if it was safe. We really need to know that we're not compromising care for patients by changing ventilation and restoring their voice early. So we set up a randomised controlled trial. We had 30 patients and 15 were in each group. So 15, that meant 15 people received early intervention and 15 received standard intervention. Early intervention involved early cuff deflation and use of a speaking valve in line with the ventilator. So that meant patients were still receiving support from the ventilator to breathe, but able to use their voice. And looking at our primary outcome, which was return to speaking, those in the early group spoke 11 days earlier. So they were speaking 11 days earlier, which was statistically significant. They were interacting with their family, interacting with their care team, talking to the doctors. And it makes care a lot easier for the doctors as well when they can understand the patients. All patients in the early group spoke, even those that may not have survived their hospital discharge. And those in the standard group, sadly, 3 people didn't get the opportunity to speak again because they weren't able to come off the ventilator. Thinking about communication, we think that's very important to patients' quality of life, and it's something that we measured as a secondary measure. And so at the time of return of voice and 6 months after, patients reported higher quality of life, particularly in domains of being understood and being cheerful. They're able to engage in their care and be the primary spokesperson, not have a family member speak for them in regards to what they needed. That wasn't statistically significant, maybe because the study wasn't powered for quality of life. And safety, the events were the same between both groups, so one group wasn't having more adverse events than the other. Both safety was equal in both groups, but it's important to note that we really need to study more patients to ensure this is an ongoing safety for patients and when doing the best things for them.